Committee's hearing at the Dirksen Federal Courthouse. Today, the committee will examine an issue on the minds of many people in Illinois and across the country, the high price of prescription drugs. It is a scandalous situation in America. People in the United States pay the highest prescription drug prices in the world, on average 4 times more than people in similar countries pay for brand name medications. For example, a well-known blood thinner, Eliquis, entered the market in 2013, 11 years ago, and it cost $3,100 annually in the United States. Same drug made by the same company for sale in Japan was not $3,100, it was $1,000. And over the past decade, the price in the United States has more than doubled from $3,100 to $7,100. Meanwhile, in Japan, the price has dropped. Same drug, same company. Why? For years, Big Pharma has abused our patent system to obtain monopolies in medications so they can charge these sky-high prices. At the same time, they spent billions of dollars to fill the airwaves with ads so patients tell their doctors they need drugs like Eliquis so they can go skiing, fishing, whitewater rafting. By fueling demand for expensive medications that are walled off from competition by clever patent schemes, Big Pharma has made American patients their profit engine. Thankfully, this administration and Democrats in Congress decided to do something about it. In 2022, Congress passed and the President signed the Inflation Reduction Act. Not one single Republican voted for it. Under this law, we have capped the price of insulin at $35 a month, saving 50,000 seniors in Illinois approximately $500 a year. We have made vaccines under Medicare free. When shingles or RSV vaccines can cost up to $300 a dose, this change creates real savings for 1.4 million seniors in Illinois. Starting in January, there'll be a $2,000 annual cap on out-of-pocket costs for seniors, meaning no matter how expensive your medications are, you will not pay more than $2,000 in copay. I want to show you a chart. In August, the Biden-Harris administration started negotiating with Big Pharma to lower prices for 10 of the most expensive drugs under Medicare, resulting in price savings of up to 79%. I know it's impossible to read. Trust me, that's what it says. As a result of this negotiation, 9 million seniors will save a total of $1.5 billion in annual out-of-pocket costs, including nearly 300,000 seniors in Illinois who take one of these 10 drugs. Remember Eliquis, the one I talked about earlier? Thanks to this new law, Medicare was able to permanently cut its price in half, taking nearly $300 off the monthly price tag for more than 100,000 seniors in our state. This is just the beginning. Next year, Medicare will negotiate to lower prices for another 15 drugs and 20 in the year after that. But just as these historic savings are starting to take effect, there are great threats to their progress. Eight pharmaceutical companies raced to federal courthouses to stop the price negotiation. And former President Trump and his Republican allies want to repeal this provision altogether. In this committee, we often hear cries that these reforms will freeze innovation because the high cost of research and development for new drugs justifies these astronomical prices. That's the pharma argument. But these critics fail to mention that taxpayer-funded research at the National Institutes of Health benefited 99% of all drugs approved by the FDA in the last decade. In other words, our tax dollars being spent by the National Institutes of Health are establishing the research necessary to develop these drugs. They also fail to mention that many pharmaceutical companies spend more on sales and marketing than they do on research and development. Too often, the prices Big Pharma charges do not reflect scientific breakthroughs, but rather manipulation by lawyers and marketers. In fact, the top 10 best-selling drugs in 2021 were covered by an average of 42 active patents that block competition and create windfall profits. The Judiciary Committee has taken a leading role in addressing Big Pharma schemes. Last year, the committee unanimously reported 5 bipartisan bills that address these anti-competitive tactics. This includes my bill with Senator Tillis, Republican of North Carolina, to improve information sharing between the FDA and the Patent Office to prevent gamesmanship. Congress needs to pass these bills into law. Drugs are not effective in treating disease if a patient can't afford to buy them. Our hearing today will explore how legislation like IRA and the Judiciary Committee bills will help ensure patient access to life-saving medications. Let me lay out the mechanics for today's hearings. Joined today by 7 members of the Illinois Congressional delegation. Some are arriving a little late with early morning appointments in other places, but I'm glad you're here. I have first recognized them to give brief statements. After we hear from our House colleagues, we will turn to our outside witness panel. After I introduce and swear in the witnesses, each witness has a 5-minute opening statement, and then we'll have questions and answers. I'll now turn to our first panel. I will call my colleagues from Congress in order of seniority, unless they are late in arriving due to scheduling conflicts. But the first was here early, and I welcome him. Congressman Danny K. Davis, you may make an opening statement if you wish.
Thank you, Mr. Chairman, Senator Durbin, and Ranking Member Senator Graham, and members of the Judiciary Committee. Let me first of all thank you for holding this field hearing to discuss an important issue to my constituents and the nation about prescription drug prices. Back in 2010, when our nation did not have affordable insurance plans for the poor and the needy, my colleagues and I on the Committees of Ways and Means, Energy and Commerce, Education and Workforce, and others in the House helped produce legislation for President Barack Obama to sign into law on March 23rd, the Affordable Care Act that overhauled the U.S. healthcare system. Healthcare reform is not health insurance, but a law that made changes to the insurance system to allow many uninsured, underinsured, and employer-based insured individuals to receive at least 10 essential health benefits in their planned coverages. The historic act reduced the number of uninsured Americans by more than 20 million, extended critical consumer protections to more than 100 million individuals, strengthened our health system by lowering the cost and requiring all marketplace insurance plans to cover treatment for pre-existing medical conditions that affects up to 129 million Americans. The ACA is a good first step and framework to strengthen and improve our healthcare system that we can build upon through future policy initiatives to provide greater access, quality services, and lower cost drugs to underserved and needy Americans throughout our country. This law staged our reform efforts to alter and change prescription drug accessibility and affordability, especially when we are confronted with drug manufacturers and pharmacy benefit managers who are producing certain medications and managing prescription drug benefits on behalf of insurers that cost too much money. One of those policy initiatives I'm talking about is the Build Back Better Act, where my colleagues and I developed legislative language with respect to high-priced drugs that are included in the Inflation Reduction Act that President Biden and Vice President Harris managed and signed into law on August 16, 2022. Through the IRA, we legislated broad changes to Medicare prescription drugs coverage and specific changes to Medicaid, the State Children's Health Insurance Coverage Program, CHIP, and private health insurance. It requires Secretary Becerra of Health and Human Services to negotiate prices for certain prescription drugs covered under Medicare, Part B, physician-administered drugs, and Part D, retail prescription drugs. By law, he is required to negotiate maximum fair prices with 10 different drug producers for 2026 and increase to 15 drugs for 2027 and 2028, and 20 drugs for 2029 and each following year. It is important that Medicare continue to negotiate lower prices on behalf of the American people. Historically, negotiating prices will not limit companies' innovation and development of better medications and cures for the American people. The Inflation Reduction Act, through the leadership of President Biden, Vice President Harris, and Democrats in Congress, took on Big Pharma and won a decade-long battle to lower the cost for millions of seniors with new benefits that cap a $35 monthly out-of-pocket cost for insulin for 4 million Americans on Medicare who use it. Free singles and other essential vaccinations, $2,000 out-of-pocket caps on prescription drugs beginning in 2025 that would save 19 million Americans an average of $400 each year in protections from drug company price hikes. Additionally, the IRA companies now must pay Medicare a rebate if their prices rise faster than inflation. From 2019 to 2020, half of all drugs covered by Medicare had prices rise faster than inflation. In the state of Illinois, 59,718 Illinoisans on Medicare who use insulin are now saving on average $519 annually, thanks to the $35 per month insulin cap. 275,956 Illinoisans are saving an average of $542 on monthly insurance premiums. For the state of Illinois, 597,880 Illinoisans will save an average of $432.70 thanks to the Inflation Reduction Act's $2,000 annual out-of-pocket cost cap effective in 2025. I thank you, Mr. Chairman, for this hearing, and you're back the balance of my time.
Thanks, Congressman Davis. Appreciate your attendance and your testimony. I know you all been wondering, I just put it on the record, I had a bowl of cereal this morning for breakfast. Before I poured the milk on the cereal, I checked the expiration date on the product and it was okay. Why is there an expiration date on the product, on dairy products? The next witness is responsible for it. She led the consumer effort to put expiration dates on dairy products as a mom and as an activist, and led her to a career in government. She is the penultimate voice in our delegation when it comes to consumer protection, and it's my honor to recognize my colleague, Congresswoman Schakowsky.
Well, thank you so much, Senator Durbin, and for having this hearing today. It's so incredibly important. I agree with everything that you said and with my colleague has said, but it's never said enough. And I want to say that in 2020, 5 of the the largest pharmaceutical companies made in profits $80 billion. This is larger than any other company in the United States of America, big tech, or big, any other organization. They made more money. And yet, Americans are paying twice to 3 times as much for pharmaceuticals, the exact same pharmaceuticals that are available around the world. I mean, I think that the American consumer is really viewed as kind of a chump by the pharmaceutical industry. am very, very concerned about the kinds of activities that Big Pharma has done to make sure that they protect their own profits. We saw during the pandemic that Big Pharma refused to let countries around the world develop their own pharmaceuticals for the COVID vaccine. They said, no, we are going to make sure that you can't get any of the information in order to be able to produce your own. So I think that the fact that many people died around the world, that the pharmaceutical companies have been responsible for that. We also know that when it comes to what that we are seeing that the pharmaceutical companies have gone to a number of the hospitals and changed the rules around it's 340B, and made it harder for the hospitals to be able to make sure when they're low-income patients and the low income they're trying to provide to them. But the pharmaceutical companies have changed some of the rules, and maybe we'll hear from some of our experts about that. I've also been very concerned about the role that the pharmaceutical companies have played to help to raise the prices. And you heard and you mentioned about the affordable, not the Affordable Care Act, but about what the Biden administration has done, what Kamala Harris has done to make sure that we were able to provide in the Inflation Reduction Act to lower the cost, to negotiate the cost of prescription drugs, to lower them. That had been done on 10 drugs, and we are going to see those prices go down. And I assure you that the pharmaceutical companies have not been happy about doing that. That we have made insulin so available to Americans at $35 a month. You know, that insulin costs about $1 to make. And yet we have seen in the past hundreds of dollars being charged by the pharmaceutical companies. Unfortunately, these benefits have only gone to people that are getting Medicare right now. And I know that the administration, our Democratic administration, has said they want it applied to all Americans. So we can make serious progress, and we should, and we need to hold accountable Big Pharma. I want to say also that I have offered legislation that I hope will pass in the next session that will allow people to import from certain countries like Canada to be able to have lower cost drugs and to import them into the United States of America. And I also am introducing legislation that would allow the Department of Health and Human Services to be able to create more affordable drugs by manufacturing those drugs. So we should be not just handing over patents to the big pharma companies to do what they want with us as Americans. And I am looking forward in the next session of Congress, being the optimist that I am, that we are going to be changing some of those rules and practices by big pharma, and that we're going to be able to get all Americans to be able to afford the drugs that they need for their lives and deserve. Let me just say one more thing. I was at a drugstore where a woman before me was told by the pharmacist how much she had to pay. And very quickly she said, well, I simply can't. And she walked away without the drugs that she needed. This is happening all across the country. It needs to stop. And with that, I yield back.
Thank you, Congresswoman, for all your work in this area. We believe in Illinois that every congressional delegation should have a physicist. And our delegation has one of those. And Congressman Bill Foster, you're next.
Well, good morning, and thank you, Chair Durbin, for inviting me to speak today. Over the past several years, I've heard from countless constituents who are struggling to afford the ever-rising costs of prescription drugs. And all too often, this means choosing between purchasing a critical medication or paying for rent or groceries. As one of the richest nations in the world, no American family should have to make a choice like that. And I was proud that the House and Senate work together and make real progress on this problem with the Inflation Reduction Act in 2022. Starting in 2025, just a few weeks away, Medicare Part D will not have to pay more than $2,000 annually towards their prescription drugs. Seniors with diabetes are already getting much needed insulin for just $35 a month. And Medicare will soon begin using negotiated drug prices with pharmaceutical companies to help bring those costs down further. However, there is still a lot of work to be done here, especially for Americans who are too young for Medicare. You know, insulin was discovered at a university laboratory more than a century ago, and the scientists who made that discovery refused to put their names on the patent, remarking that, quote, insulin belongs to the world. And now we find people still unable to afford it despite the low production cost. So more than a century later, there's a lot of work to be done here. But as we think about prescription drug pricing, there's an important balance that we must strike. New innovative drugs must be affordable for patients who need them, but we also need sufficient financial incentives for pharmaceutical companies to invest in developing new drugs, research that often fails to produce anything marketable. Now, with taxpayer-funded NIH paying much of the earliest stage and riskiest research in recent years, some of this burden has been lifted, but we still must be careful not to go too far in the other direction and potentially halt the scientific progress toward a variety of illnesses. As we all know, the presence of competition, especially from off-patent generic versions of a given drug, are one of the most reliable ways to keep drug prices reasonable. An important example of this is the worldwide race to develop inexpensive oral versions of GLP-1 receptor agonists, known to the public as Ozempic and Wegovy. You know, if you're pre-diabetic and you take these drugs, you will pretty much never become diabetic. You will lose a lot of weight, your blood will go down, and when competition drives down the price anywhere near the production cost of under $1 a day, then the world will be a better place, and the healthcare cost structure in this country will be transformed because 1/3 of all our healthcare costs are diabetes. But for now, millions of Americans are unable to access these life-altering medications because of cost, despite that the cost in other countries is 10 times lower than it is in our country. I also appreciate the Biden administration that they're taking a close look at some of the, and in some cases cracking down on potential anti-competitive abuses within the patent system that prevent or delay generic entry. Practices such as evergreening, where a pharmaceutical company makes a slight tweak to a drug to extend its patent, or pay for delay, where a company pays a generic brand to delay their entry into the market. That puts at risk the careful balance within our patent system. And Congress must support efforts to ensure our patent system is operating as intended. And finally, hand in hand with affordability, prescription drugs must also be accessible to American families. Earlier this month, there were troubling reports from the New York Times that the pharmacy benefit managers, or PBMs, were systematically underpaying small independent pharmacies for patients' prescriptions. The goal, the Times alleged, was to run these pharmacies, which compete with the PBM's in-house pharmacies, out of business. With techniques like cherry picking the most profitable drugs for their in-house pharmacies and leaving the unprofitable drugs for struggling local pharmacies. In many cases, these alleged efforts were successful, leaving many Americans, especially those in rural areas, without a local pharmacy. But I have heard exactly the same thing from local pharmacies in Aurora and in Naperville. Congress must study this issue closely and to ensure that PBMs are not engaging in anti-competitive behavior, which could impact both the accessibility of pharmacies and the prices of drugs themselves. So I thank the Senate Judiciary Committee for its hard work on preventing anti-competitive behavior in the healthcare space, and I hope the committee will consider the two issues I've laid out today. Thank you, and I yield back.
Thanks, Congressman Foster. As I mentioned at the outset, we're recognizing members in order of seniority. And now recognize Representative Krishnamurthy.
Good morning, and thank you, Senator Durbin, for hosting this hearing focused on rising prescription drug prices. Prescription drugs exist in one of the few industries that do not operate along the normal rules of supply and demand. The blunt truth is that if you or a loved one needs medicine, you will pay almost any price to obtain it. This ability to squeeze every dime from those who need medicine not only fattens corporations' bottom lines, but also leads to the creation of exploitive middlemen as surely as sharks are drawn to blood. One of these middlemen are pharmacy benefit managers, or PBMs for short. PBMs harm Americans in two ways. One, PBMs are helping to fuel ever-rising drug prices. And then two, PBMs are killing independent pharmacies, as Congressman Foster alluded to just a second ago. First, I want to get into drug prices. On behalf of healthcare payers like employers and insurers, PBMs negotiate with drug companies, acting as middlemen to create formulary lists that determine which medicines patients can be prescribed. To maximize their own profits, PBMs have implemented a so-called rebate system that requires drug companies to provide rebates based on their drugs' list prices. In exchange, PBMs include these drugs on their formularies. The higher the prices, the higher the rebates, and the more likely that a company's drug gets on the PBM's formulary. The glaring problem, however, is that PBMs do not appear to be passing along the rebates to their clients, namely the payers and ultimately the consumers. Meanwhile, PBM's pursuit of ever higher rebates drives up what they're linked to, namely drug prices. This is not some conspiracy theory. Congress, numerous states, investigative journalists, and even the FTC, as you can see from these various headlines, from even Attorney General Raoul, who's been asking the Supreme Court and other agencies to look into this issue, have now illustrated that this is a commonly understood problem. The second way in which PBMs undermine healthcare is by killing off independent pharmacies. How? Not only do PBMs act as the middlemen between payers and drug companies, they also act as the middlemen between payers and the pharmacies. And they do it in the following way. First, pharmacies buy drugs from wholesalers in anticipation of reasonable reimbursements from the PBM after the drugs are dispensed.
Sorry, what?
However, the PBMs then set these artificially low reimbursement rates. PBMs have engaged in complex schemes to either grossly underpay pharmacies for the drugs they dispense or by instituting clawbacks and what are called DIR fees, direct and indirect remuneration fees. These DIR fees mean that PBMs retroactively claw back money from pharmacies for drugs they have already dispensed in the past. CMS found that DIR fees exploded by, and this is not a typo, 107,400% over the last decade. PBMs appear to be using any and every trick in the book to continue to make enormous profits and kill off independent pharmacies. The result of these clawbacks and underpayments has been stark. The National Association of Community Pharmacists report that almost every day a pharmacy is permanently closing its doors. At this point, 73% of counties in Illinois are now a pharmacy desert, meaning there is not a pharmacy located in that county. CMS acted earlier this year to block the most egregious DIR abuses, but PBMs are still putting relentless pressure on independent pharmacies. Why? Well, surprise, surprise, the largest PBM's parent companies run their own competing pharmacies, which now dispense a whopping 80% of all prescriptions in the country. PBMs have the power to kill off their competition, and they are doing just that. The result of PBM control and manipulation is that drug prices are going up, pharmacy closures are going up, and guess what? PBM profits are going way up. PBMs, I would suggest, stand for pretty big markups. That's what PBMs are at this point. However, there's some cause for hope. Elected officials on the state and federal level from both parties, including in Illinois, agree that PBMs need to be reined in. For instance, we should pass as soon as possible much needed PBM reform legislation like the bipartisan Pharmacists Fight Back Act. This bill is the most comprehensive approach to PBM reform yet, and I believe meaningful reform of the PBM industry is within our grasp, even within this Congress. Senator Durbin, thank you again for your yeoman's work to lower prescription drug costs and for holding this hearing. I'm honored to have been included. Thank you.
Thank you very much, Congressman. I just parenthetically add, if you've been to a Walgreens drugstore lately to fill a prescription, you know what you're going to find? A line of 12 people in front of you. I see some heads nodding in the audience. And you think to yourself, they're closing drugstores. They're going to close some drugstores. And yet the demand is so high they can't fill the requests of customers who walk into their stores. Something's wrong with this picture, and I think it's PBMs. They're stepping in, complicating this market relationship, and the consumer is the ultimate price, will pay the ultimate price. So I thank you for raising that issue.
Yes, sir.
Next is Congressman Sean Castanen.
Thank you, Chair Durbin, for doing this, and honored to be invited. So a couple of years ago, I had the opportunity to meet with some of the doctors and administrators at the Mayo Clinic, and was chatting with them about how they measure success as one of the more successful health clinics in our country. And they said their metric is this mortality amenable to health care. How many people die every year but for their access to health care? Now, maybe that's because there was an oversight on the part of the hospital. Maybe maybe there weren't beds available. Maybe they couldn't get the right specialist. Maybe they didn't have insurance. All of these people are people who should have lived. And they measure that success for their hospital. They measure it for their state. They compare to others. You can look at it countrywide. And in the United States last year, a little over 1 million people died who should have lived but for shortcomings in our healthcare system. That's 336 per 100,000 if you want to normalize it on a per capita basis. And to put that in perspective, that is more than twice the rate of the Swiss, the Japanese, the Australians, the Swedish, the Netherlands, the French. I could go on down that list. We have worse health outcomes than virtually every other industrialized country in the world. And on top of that, we pay more for health care than any other country in the world. About $13,000 per capita per year, $4 trillion. So if we were paying a lot and getting great outcomes, okay, that's a trade-off. As it is, we're paying a lot and not getting robust outcomes. If we step that back, the fastest growing cost in the healthcare system is pharmaceuticals. In 2004, 1% of their expenses were pharmaceuticals. Last year was 14%. It's growing faster than anything else in the system. I think several folks have talked about why it is that we have said that Medicare shouldn't negotiate pharmaceutical prices, and that's a rich conversation. But we should point out that it is insane. If you were to tell the American people when you go buy a car, you can't negotiate with the dealer. When you buy a house, you can't negotiate. None of us would call that a competitive market. And somehow we've got this idea in our head that, well, competitive markets will fix this problem. They haven't. They failed. In 2019, the House passed H.R. 3 to fix that problem, to not only give Medicare the right to negotiate, but compel them to negotiate. And I don't want to be partisan, but if we're talking about epidemiology, we need to use all the statistics. Every single Democrat voted for that bill, and only 2 Republicans in the House voted for it. That bill would have given Medicare the ability to negotiate prices, would have capped out-of-pocket costs, would have added dental, vision, hearing to Medicare, a number of other reforms as well. As you know well, Chair Durbin, the Senate was led by Republicans at that time and chose not even to bring it up for a vote. Fast forward 2 years later, and as you mentioned in the Inflation Reduction Act, we then passed several of those provisions in the bill, all of them, but now we've got 10 drugs that are available for Medicare to negotiate, which will expand next year. Out-of-pocket costs are capped to $2,000, $35 price on insulin, caps on ACA expansions on ACA subsidies. Not a single Republican voted for any of those. I don't want that to be partisan, but it is the reality that we would not have made that progress but for who was in power in 2022. The result of that, just in my district in Illinois 6, is that there are now 23,000 more people who have health insurance, who are saving an average of $1,000 a year. Just in one congressional district, 4,300 people who are saving $490 a year on average on insulin. 24,000 people who are saving on average $533 on prescription drugs. And that's going to go to 34,000 next year. Illinois-wide, I think as Congressman Davis pointed out, the numbers I've seen is that folks are going to save over $120 million, almost 500,000 people in Illinois. And oh, by the way, that's a $6 a year savings in Medicare, which means that our fiscal health as a nation is better and people are healthier and people are saving out-of-pocket costs. Now, having watched the Bears game this weekend, the last thing I want to do is to celebrate before the game is over. And make no mistake, this game is not over. We have made terrific progress. And maybe it's appropriate to do a little shimmy in the end zone after the referee puts his hands up, but we haven't won the game yet. And I hope that as we move forward in this Congress, we can simply recognize that there is not a business in the world that comes to Washington and says, I wish my industry was more competitive. It is crazy that we had to give Medicare the right to negotiate. We've gotten that to 10 drugs. We'll expand it next year. They should have the right to negotiate all drugs. As Congressman Krishnamurthy has pointed out, pharmacy benefit managers are not designed to create competition. Quite to the contrary, it appears that they are getting in the way of competition. We need to expand the number of covered drugs. We need to make sure that these benefits cover the whole system. And I hope someday everybody who has the privilege to serve and to have public service recognizes that you either are or are someday, God willing, will be a senior citizen. Your constituents include large numbers of senior citizens. 100% of Americans, I've polled this, would like to be healthier, would like to spend less on drugs, and would like to see our deficits fall. And I hope that that leads us all to make this a robustly bipartisan commitment to competition, markets, and a healthier population in the very near future. Thank you. I yield back.
Thank you very much. And if I'm not mistaken, the report in the Heritage Foundation, Project 2025, would have eliminated the power that we have given to our government to negotiate lower drug prices. So in fact, this issue is on the ballot next Tuesday for voters to decide whether to move forward with this or not. Congressman Garcia.
Thank you, Chairman Durbin, for convening this most important hearing on this critical project, topic rather. There's no reason that the wealthiest country in the history of the world, at a time when we're confronting the consequences of health disparities that were laid bare by the COVID pandemic, that patients still cannot afford the everyday medications that they need to live a healthy, dignified life. Under the Biden administration, Congress has taken unprecedented steps in the right direction to lower the sky-high cost of prescription drugs. I'm proud to have participated in a progressive push to ensure that prescription drug costs were addressed in the Inflation Reduction Act. The bill, of course, has capped, as we've discussed, a $35 per month for seniors and finally allowed Medicare to begin negotiating for other lower drug prices. Prices for the first 10 drugs negotiated were released this summer. When they go into effect in 2026, they will start saving customers up to 76%, hundreds in cases, thousands of dollars per month. The new prices are expected to save $1.5 billion in 2026 alone. But despite remarkable progress, these gains only address a fraction of the enormous need for lower drug prices for patients not covered by these programs. For example, I represent a congressional district that is over 65% Latinos. And Latinos are nearly twice as likely to have diabetes than non-Hispanic whites. So while the insulin cap is a lifesaver for people who are covered, everyone else, even those with private insurance, does not cover the insulin. And they're still paying hundreds. That's a policy issue and one created when Republicans blocked a broader insulin cap from the final version of the Inflation Reduction Act. That comes on top of the fact that many of my neighbors are already confronting health inequities like underinsurance, food deserts, and a lack of nearby health facilities that contribute to the overall well-being. So, for the tens of thousands of individuals in my district, approximately 94,000 people without insurance because they're immigrants or undocumented or otherwise ineligible, we've got to find a new approach. And while the impacts of the targeted drug pricing legislation we've passed demonstrates how far we've come, the remaining gaps show us where we need to go toward comprehensive legislation that addresses anti-competitive behavior by pharmaceutical companies at its root. That's why I'm proud to be here at this Senate Judiciary hearing. And as a new member of the House Judiciary Committee, it's an important issue that we've got to tackle together. We must confront practices that corporations use to prolong market exclusivity for profitable drugs. We must call out the billions spent on lobbying, campaign contributions, and stock buybacks by big pharma companies that simultaneously claim they cannot afford to lower drug prices. It's price gouging, plain and simple, and it's got to stop. So again, I deeply appreciate the opportunity to be here today with my colleagues, and I look forward to working together with everyone here, panelists and my colleagues in the House and Senate to work toward a common goal of affordable health care for all. Thank you.
Thank you, Congressman. Congressman Ramirez.
Thank you, Chair Durbin, for holding this important hearing. I'm really honored to join my colleagues here in the House and listen to expert testimony around an issue that deeply affects my constituents. In the words of my father, Luis Ramirez, la medicina está demasiado cara. The cost of prescription drugs in America is too darn, we'll say, high. Too often I hear from my constituents talk about the impossible choices they have to make between paying rent, paying for groceries, or affording their inhalers. And in our nation, a person with asthma pays about $1,830 per year just for life-saving emergency Albuterol, $1,830. And I'm grateful to have been part of the movement in Illinois to cap the prices of prescription drugs. I was in the Illinois State Legislature when SB 667 came to the floor to cap the price of insulin, and I had the honor to be a co-sponsor and vote yes on that bill. And of course, I'm grateful for the historic legislation passed by Democrats to cap the price of insulin and allow Medicare to negotiate the price of prescription drugs. But folks, we're here because we know we have to do so much more. Too many lives are on the line. You've heard it from my colleagues today. Our family, our friends, our neighbors, our constituents, they depend on us to continue to advance efforts that reduce the cost of and increase the access to medication. You see, in Illinois, my district 3 is comprised of working people who depend on these efforts. 12% of my residents have income below the poverty line. Over 82,000 people have no health care insurance coverage whatsoever. 233,000 of them rely on public programs for coverage. And multiple communities qualify as medically underserved. But when the unchecked corporate greed of pharmaceutical companies meet the lack of proper regulation of prescription drug prices, families in my district and all of our districts suffer. In my district, families have found relief in community health centers like Erie Humboldt Park Health Center that provide essential comprehensive health care. And because regulatory programs created by Congress, like the 340B drug discount program, healthcare providers that serve low-income and uninsured communities are able to purchase drugs at a lower cost and help patients afford their medication, their insulin, their inhalers, their blood pressure medication, their Narcan, their PrEP, and more. In addition to helping patients afford their medicine, we know that community health centers provide the high-quality, comprehensive care patients with chronic conditions need to thrive. Programs like the 340B drug discount program and high rates of utilization of community health centers across Illinois show us how critical it is for Congress to take action to address how unregulated, greed-driven drug pricing holds our families back from realizing a better healthcare outcome and fuller, more vibrant lives. And look, the truth is that the prescription drug pricing system is intentionally complicated and confusing. That's why we need all those charts, Raja. It's a predatory practice, and everyday Americans struggle to understand what is covered and how much it's going to cost them. It's clear we have both the opportunity and the responsibility to address this broken system that regularly puts profits over people's well-being. And for the last 2 years, I've had the privilege to serve in the Veteran Affairs Committee, where I've seen firsthand the potential of models that prioritize coverage and life-saving medications for our communities. And as I work with my colleagues in the committee to ensure the proper implementation of the historic PACT Act, it is clear that we have the models, we have the tools, and we have the capacities to ensure that every family has access to care and assistance they need. But we have to continue to advocate for Medicare for all, to provide comprehensive benefits to every person in the United States, including primary care, including vision, dental, prescription drugs, and more. We have to bring the full power of the federal government, regulation, legislation, and the word you've heard here from my colleagues over and over, negotiation, to fight for our constituents so they never have to forgo necessary prescriptions. Today, I look forward to listening to experts about the crucial steps we can take together to ensure that everyone, regardless of zip code, regardless of migration status, have access to the medicine they need, they deserve, to care, and the care that they deserve, and the help that we know our nation can provide. Thank you, Senator Durbin, for this opportunity and for this hearing.
Thank you, Congresswoman. Each morning in the Senate, the Republican leader and Democratic leader make statements, and I am usually there to hear them. One recent statement made by the Republican leader, Mitch McConnell, was in reference to the negotiation of drug prices. He referred to it as, quote, pharmaceutical socialism. Pharmaceutical socialism. I'm glad you brought up the fact that the Veterans Administration has been negotiating drug prices for decades, saving the taxpayers a lot of money in the process and making sure that the men and women who served our country still receive the very best when it comes to medical assistance. I don't think that's socialism. I think that's basic to America and our democracy. I want to thank you for raising that issue. I want to thank my colleagues for joining me this morning. All of your contributions were very positive and be part of the record. And in the process of changing out the panel to the second panel, I want to thank healthcare leaders from around our state who joined us here at this hearing, including Illinois Public Health Director, Dr. Samir Vorha, State Senator Mike Simmons, former intern in Durbin's office, and representatives from hospitals and health centers, Lawndale Christian, Access, PCC, AHS Family, Rush, Sinai, and Lori Children's, along with the Illinois pharmacists who've joined us as well. So I thank my colleagues for joining me this morning, and you are now officially dismissed.
All right.
That's the moral of today. That's the message of today's hearing.
I don't know, actually. I'm going to pass it on to the
If the 5 members of the second panel would approach the table, I'd appreciate it very much and remain standing for a moment.
Bye.
If you would please raise your right hand. Do you affirm the testimony you're about to give before the committee will be the truth, the whole truth, and nothing but the truth, so help you God? Let the record indicate that the 5 witnesses luckily all answered in the affirmative. I'd like to introduce them. Our first witness is Kwame Raoul, 42nd Attorney General of the state of Illinois. He served as Illinois' chief legal and law enforcement officer since 2019, assumed this role after serving for 14 years as an Illinois state senator, previously served as a prosecutor in Cook County and staff attorney for City Colleges of Chicago. We're also joined by Professor Rachel Sachs, a professor of law at Washington University in St. Louis, where she also serves as a faculty scholar with the Institute for Public Health and faculty fellow with Cordell Institute for Policy in Medicine and Law, and much more, I know from earlier conversation. Our next witness is Dr. Anthony Douglas, general surgery resident physician at the University of Chicago Medicine, where he focuses on trauma and acute care surgery. Also the founder and first fellow of the University of Chicago Surgical Advocacy Fellowship. Thank you for being here. Next, joined by Michael Sandsmark. Mr. Sandsmark is the director of pharmacy at Iroquois Memorial Hospital and resident home in Watseka. In 2023, Iroquois Memorial Hospital was designated as a critical access hospital by the Centers for Medicare and Medicaid Services, recognizing the key role that this facility plays in providing health care in that part of the state. Our final witness is Deanna Brandt, the retired executive assistant from Countryside, Illinois. She is a Medicare beneficiary, and I look forward to hearing her perspective on what it's like to cope with these high costs of prescription drugs. Thank you for joining us. I'm going to let the Attorney General kick it off. Take it away.
Good morning, and thank you, Mr. Chairman. Thank you for inviting me to speak on this important issue. As Attorney General, I take seriously my office's fundamental function to protect the health and wellness of Illinois citizens. High prescription drug prices harm Illinois patients by obstructing access to treatments needed to sustain their health and well-being. Without access to affordable medications, medical conditions worsen, patients' overall health outcomes decline, and for some patients, it can be fatal. According to the U.S. Department of Health and Human Services, from January 2022 to January of 2023, more than 4,200 drug products had price increases, of which 46% were larger than the rate of inflation. With these ever-increasing costs, patients may stop taking their medications as prescribed or eventually abandon treatment altogether. In addition to the direct burden on Illinois consumers, high prescription costs also impact the state at large because they are significant payers of healthcare services. State dollars pay for prescription drug use by state employees and their dependents, the use by people housed by the Department of Corrections, and Medicaid beneficiaries. In Illinois, about 3.9 million people are enrolled in Medicaid. Pharmaceutical companies and pharmacy benefit managers, known as PBMs, must be more transparent about their pricing and business practices. They should also be held accountable for unnecessary and overly burdensome increases in prices for prescription drugs. As mentioned earlier by several speakers, the original purpose of PBMs was to negotiate on behalf of employers, government payers, and consumers to minimize overpricing by manufacturers. Instead, PBMs have made the pharmaceutical market more opaque and have driven up prescription drug pricing. My office and those of other state attorneys general have worked to hold PBMs accountable. However, before expounding on the actions my office has taken, I do have to mention that the scope of what I can share and answer is limited due to ongoing litigation and investigations that are subject to confidentiality agreements. I'm restricted from commenting on certain pending matters. I want to emphasize that I have used multiple tools available to go after bad actors in the industry. We have used our authority under the Illinois Consumer Fraud and Deceptive Business Practices Act, the Illinois False Claims Act, and antitrust laws to target the prescription affordability crisis from every possible angle. PBMs profit from fees charged to market participants, and by reimbursing pharmacies less than PBMs is paid plans for dispersing medications. We believe PBMs have engaged in practices that drive up their own profits at the expense of patients and the state actors who have contracted with them. My office has uncovered practices that have allowed PBMs to largely overcharge state agencies through their contracts with the state, and I've been successful in bringing money back to the Illinois investigations. For example, as a PBM for Illinois Medicaid program, Centene subsidiaries delivered pharmacy benefits to Illinois state agencies, such as the Illinois Department of Healthcare and Family Services. We initiated an investigation that determined that Centene's subsidiaries allegedly submitted inaccurate pharmaceutical reimbursement requests that failed to accurately disclose the cost of pharmacy services. In addition, requests for reimbursement did not disclose available pharmaceutical discounts and improperly inflated dispensing fees. On September 27, 2021, my office, on behalf of the state, executed a settlement agreement that required Centene to pay the state over $56 million. As a result, as recently as June 24 of this year, my office recovered $45 million to the state through a settlement agreement with CVS after an investigation under the False Claims Act showed that CVS, as a PBM contracted with the state, improperly failed to pass rebates back to the state from April 1, 2020 through September 30, 2023. PBMs have largely been unregulated, and recently, as earlier this year, I joined a bipartisan group of AGs calling on Congress to reform the way PBMs do business. Federal legislation is needed to curb undue price increases and to increase transparency around the way PBMs operate and set prices. In the absence of federal regulation, states have passed their own regulations, which have been met with pushback from the industry. There's a petition pending in front of the United States Supreme Court to determine whether federal laws preempt state laws that regulate PBMs. This past summer, my office joined a bipartisan coalition of states urging the court to review a decision from the 10th Circuit holding that federal laws preempt Oklahoma laws regulating PBMs. The coalition seeks to protect consumers by assuring that states can regulate PBMs as part of our efforts to address access and affordability to prescription drugs. In December of 2022, my office originally filed a complaint in Cook County against PBMs and manufacturers alleging violations of our Consumer Fraud and Deceptive Practices Act for engaging in an insulin pricing scheme. Our case is now in an MDL pending before the district court in New Jersey. The complaint alleges that insulin pricing scheme has caused the cost of insulin to skyrocket. To be clear, insulin costs these manufacturers less than $2 per unit to produce, yet prices can range from $300 to $700 per unit. Our Antitrust Bureau investigates the conduct of brand drug manufacturers who engage in illegal activities to delay entry of generic competitors, which drives up prices for consumers. Such activities could include agreements with generic companies to delay entry into market, product hopping schemes, and exclusive contracting schemes which prevent drug companies from accessing the components needed to manufacture these drugs. Our Bureau is working with nearly all other states on litigation against the generic drug industry for engaging in price-fixing conspiracies involving hundreds of generic drugs. The state coalition has already settled with several individuals and 2 corporations who have agreed to provide monetary relief and substantial cooperation. In 2023, my Bureau, in partnership with the FTC and several other state AGs, was able to secure a settlement agreement with Amgen, one of the world's largest biopharmaceutical drug companies, to address the potential competitive harm that would result from Amgen's purchase of Horizon Therapeutics. The settlement resolved the potential anti-competitive acquisition and prevents Amgen from engaging in anti-competitive actions to disadvantage any product that would compete with these drugs. The agreement requires Amgen to submit annual compliance reports and a monitor is in place to oversee compliance. Mr. Chairman, these are examples of how my office has worked to rein in the ongoing problem of prescription drug overpricing. They're not exhaustive examples. We will continue to do so. I'm thankful to the committee for shining a light on these challenges, and I hope that we can collectively work on behalf of Illinois patients, employers, and the government payers to reduce the price of prescription drugs.
Thanks, Attorney General. Professor Sachs.
Chair Durbin, my name is Rachel Sachs, and I'm a professor of law at Washington University in St. Louis, where my research focuses on innovation and access to new pharmaceuticals. Thank you for the opportunity to testify about the role of competition in making prescription drugs more affordable for patients and how this committee might address these issues. All views I offer today are my own. Over the last 40 years, Congress has focused on competition from lower-cost generic and biosimilar versions of branded prescription drugs as the primary tool to bring down prices and promote access to affordable medications. 1984 saw the passage of the Hatch-Waxman Act, which created a path to FDA approval for generic versions of small molecule drugs. When combined with state laws allowing pharmacists to substitute generics for branded drugs, Hatch-Waxman has been largely successful. Today, generic drugs quickly take over 80% of the branded drugs market share, and multiple generics can drive down prices by over 90%. Of course, ongoing focus on branded drug manufacturers' attempts to delay generic competition matters, and I'll return to that. The Biologics Price Competition and Innovation Act, as enacted in the Affordable Care Act in 2010, created a path to approval for biosimilar versions of biological products. To date, this law has been less successful at creating competition than has Hatch-Waxman. Just 61 biosimilars for 17 biologics have been approved to date, and many have not yet been marketed. Even marketed biosimilars struggle to gain market share and have driven down prices by a smaller amount. The relative weakness of biosimilar competition is traceable to several factors. In my written testimony, for example, I refer to patent listing distinctions between the orange and purple books, the interchangeable designation, and comparatively weak state substitution laws as legal drivers. The Inflation Reduction Act, or IRA, and its Medicare drug price negotiation program also looks to generic and biosimilar competition as the primary tool to drive down drug prices. Recognizing that Hatch-Waxman and the Biosimilars Act have not always succeeded in enabling generic and biosimilar entry, only if such competition has not emerged does the IRA envision a role for Medicare to negotiate the prices for drugs it purchases as a market participant. The IRA only permits a drug to qualify for negotiation after it has been FDA approved for many years, and a drug with an approved and marketed generic or biosimilar is not eligible for selection for negotiation. Hatch-Waxman and the Biosimilars Act aim to support approval of generics and biosimilars. This approval is necessary for competition, but is not sufficient to enable it. Take the biosimilars example. Even where a biosimilar is approved and marketed, it must be covered by insurers, physicians must prescribe it, and pharmacists must substitute it. Patents matter for creating competition at the approval stage, but legal changes must go beyond patent law to include insurance coverage, physician prescribing, and pharmacy substitution. This committee ought to consider legislation to improve competition, but a full response will require support from other committees with distinct jurisdictions. First, this committee should continue to focus on the approval of generics and biosimilars, where the PTO and patent law play key roles. This committee has already taken up several bills responding to branded manufacturers' efforts to discourage generic or biosimilars. The Federal Trade Commission's recent challenges to over 400 patents allegedly improperly listed in the Orange Book also fall into this category. Second, coverage. Many insurance coverage decisions are mediated through pharmacy benefit managers, or PBMs, about which we've heard already. PBMs have been criticized, including for the ways in which they sometimes appear to limit access to lower cost products. Both the Federal Trade Commission and several state attorneys general have sued the nation's largest PBMs over their conduct in the market for insulin in particular. This committee should consider its role in PBM reform, including potentially supporting the commission's complaint. Third, prescription. This committee might work collaboratively with others to encourage the prescribing of lower cost products. For example, experts have argued for reforming the Medicare Part B payment system, arguing that it encourages clinicians to choose higher priced products over lower priced ones. Fourth, substitution. State biosimilar substitution laws typically only permit substitution where the biosimilar is deemed interchangeable by FDA. Most approved biosimilars lack that designation. This committee might support efforts to alter state biosimilar substitution laws, as well as efforts by other committees regarding the interchangeable designation, as FDA has requested. This committee should support competition to make prescription drugs more affordable for patients. Chair Durbin, I appreciate your focus on this important issue, and I look forward to answering your questions.
Thank you very much. Dr. Douglas.
Good morning. Thank you, Senator Durbin, and the members of your Judiciary Committee for the opportunity to testify today, also for your investment in this important issue. My name is Dr. Anthony Douglas II. I'm a general surgery resident physician at the University of Chicago. I'm here on behalf of my patients as well as Citizens Action Illinois, and my thoughts are my own. As physicians on the front lines, we have a pulse on how everyday Americans are affected by high out-of-pocket prescription costs. We make and carry out the plans for patients in the inpatient and outpatient settings. We perform the operations, and we guide Americans across this country to recovery. For physicians like myself, one of the most difficult conversations to have are those with patients over the phone when they are at the pharmaceutical counter. As I sit before you, I can hear the worry, the desperation and embarrassment of my patients from the CVS and Walgreens counter saying, "Dr. Douglas, I cannot afford this medication." I remember the face of the woman with type 1 diabetes who came to our emergency department with appendicitis, who was not taking the insulin she was prescribed. When I asked her why, her answer was simple: "I cannot afford it." Her surgery was delayed. I sat and watched her dangerously high blood sugars improve each day with angst, hoping she didn't have a complication as we waited. Senator Durbin, I have story after story of people balancing the cost of medications to sustain their livelihood and the cost of their mortgages, utilities, childcare, and groceries. And they almost always choose the more pressing immediate needs over their medications. My father, who is in the audience today, was prescribed Jardiance for his type 2 diabetes. It cost him $660 a month to refill. He has since been switched to a more affordable but less effective medication after free samples from his physician ran out. In an Uber ride, Carol, a middle-aged woman, drove me to the airport. After asking me what I did for a living, she divulged that she had a kidney transplant a week ago. I scolded her for not being at home recovering, and her response made me feel ashamed. She said she had no choice but to drive Uber because the cost of the drugs to keep her body from rejecting her brand new kidney were too great. And I'd be remiss if I didn't share this story. I spoke at a retirees meeting about a week ago, and a member of the audience came to tell me about his friend who was a former police officer who developed a blood cancer and was depleting his family's financial reserves to pay for the medication to treat his blood cancer, and stopped taking the medication to let his disease run its course in order for his family to have finances to survive. In our state of Illinois, a survey of adults revealed that 1 in 4 people split, ration, or take sips of their medications to prolong needing a refill. That means approximately 20 Americans in this room right now are not taking their medications as they are prescribed because they must delay paying to refill the prescription. As a physician, I can tell you drugs do not work like that. Medication non-adherence accounts for 25% of hospitalizations and 125,000 deaths a year. One of the significant drivers of how much our country spends on healthcare is inefficiency. The lack of prescription affordability leads Americans to visit the emergency department or be admitted to the hospital for conditions that could be effectively controlled at home if they simply had access to the appropriate medications. That is inefficient. In 2023, according to the U.S. Department of Health and Human Services, 4,200 drug prices had price increases, and 46% of those increases were larger than the rate of inflation, as alluded to earlier. The average price increase was 15%, or about $590 per drug. The Inflation Reduction Act was a pivotal step towards addressing the rising cost of prescription drugs for Medicare Part D patients. The act helped to reduce the price of a drug like Xarelto, a blood thinner that I prescribe almost daily, from $517 to $197, a 62% cut. Other drug prices were cut between 38 to 79%. This and the annual drug spending cap for senior Americans will make medications more affordable and save lives. But in my experience, Medicare Part D enrollees are merely a fraction of the population that is suffering from the rising costs of prescription drugs. We cannot forget about a number of other vulnerable groups as well. The young and uninsured who unexpectedly develop an illness, the middle working class who develop chronic diseases and whose employer-based or private insurance doesn't quite relieve the cost, ethnic minorities who are disproportionately uninsured, unemployed, living in poverty, and victims of health inequities. All of these populations are suffering. We spend hours as physicians filling out prior authorizations just to find out that even after insurance kicks in, the cost of a medication is still out of reach for some patients. We need additional intervention at the federal level related to patent abuse, price transparency, and PBM practices. The pharmaceutical industry threatens that regulation of drug pricing would force them to remove drugs from the market, attempting to incite fear among Americans who are desperately in need of their medications. In reality, the pharmaceutical industry spends more in advertising in America than research and development. As a result, the citizens of these United States pay more in drug costs than any other developed country. Why should a state like Florida have to import prescription drugs made and manufactured here in the United States from Canada to lower the cost of medications for their citizens? This price gouging must end, and it must end through federal regulation. Drugs do not work if people cannot afford them, and I cannot fulfill my duty as a physician if my patients cannot follow their doctor's orders. Thank you.
Thank you, Dr. Douglas. Dr. Sandsmark.
First of all, thank you, Chairman Durbin, for inviting me here today to discuss prescription drug prices and their effects on my patients. As a pharmacist, I have had countless discussions with patients at the pharmacy counter about their prescription drug costs. It is never an easy task to explain to a retired teacher, a grandma, or a neighbor that their prescription copay will be over $600 simply because it is a new year, or that the prescription that was $47 last month is now $260 because they are now in the Medicare coverage gap. For the last 5 to 10 years, I have been having these conversations with my patients all too frequently, as the cost of prescription drugs have far outpaced inflation. These conversations often led to patients leaving prescriptions behind or rationing previously filled prescriptions solely due to the excessively high cost. At the beginning of the year, I see patients delaying medication refills because of the high Medicare Part D deductible. As the year progresses and patients begin to enter the Medicare Part D coverage gap, we often see patients stop filling their most expensive medications for the remainder of the year. These conversations just became disheartening to our patients and were burning out myself and my dedicated pharmacy staff. So we set out to try and avoid these conversations altogether. Even before the patient arrives at the pharmacy counter, my staff and I explore all ways to reduce our patients' costs and bridge these coverage gaps. We want to ensure that the patient leaves the pharmacy with a prescribed medication or a therapeutically equivalent medication in their hands. Being a part of a critical access hospital affords my staff the time to advocate for our patients and more closely work with providers, nurses, social workers, and medical assistants to overcome these financial barriers. It often takes the entire healthcare team across multiple departments to connect patients with manufacturer samples, find a free trial coupon, enroll patients in a prescription assistance program, explore opportunities to the 340B drug savings program, and if all else fails, paying for the patient's copay out of our own pockets. Since the passage of the Inflation Reduction Act, our patients have certainly benefited directly at the pharmacy counter. This legislation has drastically improved the financial stability of many of my elderly patients who are almost all living on a fixed income. I am reminded of a type 1 diabetic farmer that was spending nearly $7,500 a year solely on insulin copays prior to turning 65 in 2022. He now spends less than $900 annually because of the $35 a month cap on copays for his Novolog and Lantus that he is prescribed. Another way that we have helped reduce our patients' prescription expenses is by counseling them on selecting the right Medicare Part D plan each year. Unfortunately, the open enrollment period has typically led me to explaining ever-increasing prices and patients becoming increasingly worried about their household budgets. However, this open enrollment period has led to entirely different feelings for my patients. I'm looking forward to showing them their 2025 plan comparisons because more out-of-pocket savings will be rolled out to all patients, not just those dependent on insulin. Last week, I counseled an 84-year-old retired home healthcare aide suffering from heart disease and type 2 diabetes. She takes 13 medications, including Entresto, Xarelto, Victoza, Praluent, and Jardiance. She will see her out-of-pocket costs fall from over $7,000 in 2024 to only $2,000 in 2025. These are life-changing savings for many of my patients, and now my staff and I can focus more on clinical aspects of our profession instead of chasing down coupons and dealing with manufacturer samples. The Inflation Reduction Act not only has helped reduce prescription drug expenses, but has also had a dramatic effect on one of the most important medications we have in our toolkit today, vaccines. At Iroquois Memorial Hospital, the pharmacy staff helps lead a vaccination program across many care areas, including long-term care residents, patients in our rural health clinics, and acute care patients. The expansion of coverage for many recommended adult vaccinations, including shingles, RSV, and COVID-19, has undoubtedly led to increased vaccination rates among our patients. 2 years ago, nearly all patients interested in receiving the 2-dose shingles series first inquired about the cost before we ever discussed effectiveness or potential side effects. Unfortunately, a large percent of these patients would decline receiving the vaccine when they discovered their out-of-pocket costs were nearly $400 for the series. Today, these vaccines are fully covered for Medicare beneficiaries, and the conversations I have with patients are centered around the importance of receiving the vaccines instead of the cost. Although current legislation has led to significant reductions in the price of prescription medications to a large segment of the U.S. population, there is still more work to be done. I see an ever-increasing need to legislate meaningful cost reductions for all patients in the United States, especially those working-class Americans with employer-sponsored health insurance. As we see type 2 diabetes and heart disease diagnosed in patients in their 20s and their 30s, it is increasingly important to ensure these patients and their families can afford to treat these diseases effectively for decades during their most productive years. Thank you again, Senator Durbin, for the opportunity to share my experience and those of many of my patients here today.
Thank you, Dr. Sandsmark. Ms. Deanna Brandt.
Thank you. Chairman Durbin and members of the committee, my name is Deanna Brandt. I live in Countryside, Illinois. I'd like to tell you a little bit about my experience in using the Part D section of Medicare. I've been on Medicare since 2002. For about 19 of those years, I was on very few prescriptions, and for the most part, they were generic and considered tier 1 drugs and very inexpensive. I was very healthy, so very few problems. In 2021, I developed COVID, although I was unaware with no symptoms. However, I developed atrial fibrillation, or AFib, maybe from COVID. It was detected when I was sent to the hospital to be treated for the AFib. From 2021 to the present, I have had RSV, 2 back surgeries, a bladder tumor, and stones in my bile ducts. Needless to say, it has required more prescriptions, but happy to say I now feel very well. 3 of the medications I take are quite expensive and put me in the coverage gap pretty early in the year. In 2021, I was able to stay in the initial coverage section until I had to deal with AFib. And then I was pushed very quickly into the coverage gap in October. In 2022, it was May, 2023, April, and this year I got all the way to June. My out-of-pocket costs in 2021 were $4,533. In 22, they were $7,019, just $31 from the catastrophic stage. In 2023, it was $7,528, and I did reach the catastrophic stage. To date this year, I've spent $5,634, but I will have at least another $1,200 through the end of the year. Although I have Social Security and a pension, and therefore on a fixed income, I do have to watch my spending. I live in a moderately priced condo, have a mid-price car, and I don't go on vacations. The amount I spend on drugs was more than I received from the required distribution from my 401k. Instead of saving that money, I paid for drugs. I do like to assist my grandchildren with their school loan debt, but the last 3 years I was unable to assist. For others, that $7,000 would mean their basic needs, like food, housing, or transportation are greatly affected. The average person spends about $3,000 in groceries a year and about $1,500 a month in rent. For many, the cost of their drugs is a decision of whether they do or do not pay for their basic needs. I also was at a pharmacy one day when a lady came to pick up her prescriptions. They told her one prescription. They told her the price. I don't remember exactly what it was, but it was well over $100. She stood there for a minute and then said, "I don't have that kind of money." And she walked away from her counter without her medication. My regret was that I didn't react and offer her some help. I have a friend that's in a study for cancer. The drug she is taking would cost her $4,000 a month if she wasn't in the study. That is more money than most people receive from Social Security. She would not have been able to afford to pay that amount. She is thankfully in remission at the moment. I have another friend that pays $1,000 a month for a cream for a dermatology problem. There's assistance for low-income people, and there is a group of people with enough disposable income to afford medications. It is the group in the middle that seemingly bear the heaviest burden in this matter. Prescriptions that are necessary for quality of life should not be beyond any senior, let alone any other age group's ability to afford it. Being healthy should not just be for people with discretionary income. Food for thought. I sometimes question how the incessant advertising of prescription drugs on all forms of media affect the overall drug cost. Could that money spent be repurposed into lowering drug costs? I cannot decide which drugs I take, only my doctor can. My friends and I are very grateful for Medicare and the drug program. We certainly don't want to go backwards. It just seems for the cost for drugs that are considered tiers 3, 4, and 5 are very excessive. We're all grateful that next year there'll be a cap on our medications at $2,000. It could be the difference for many of eating or taking their medications. Thank you for your time and your efforts to lower prescription drugs. Keep working on this to make it better for me and others.
Thank you for being here. Sincerely. Thank you very much. I'm sorry you don't consider this trip a vacation since you do.
It is kind of
vacation, a little ways. But you're telling your personal story. It makes a difference. It really does make a difference. I'm going to ask you a few things about it in a minute. What a panel. What a great panel. Thank you all for being here. Dr. Douglas, thanks for telling your personal story your perspective as a physician. It really is meaningful. You mentioned that to manage his diabetes, your father was prescribed Jardiance, which he was unable to afford. I think we have a chart on Jardiance. As you can see from the chart, Jardiance manufacturers steadily raised the drug's price over the last 5 years, from around $450 to nearly $600 for a 30-day supply. Your father lived through this. Under the Inflation Reduction Act, Medicare is finally able to negotiate the price it pays for certain drugs, including Jardiance. And the Biden-Harris administration was able to negotiate the price for Jardiance down to $197 a month, a 66% discount over the high price your dad faced. Tell me what that price reduction you think will mean to your patients.
Well, in short, Senator Durbin means saving lives. I mean, people who have access to the medications that they need because they are affordable and within reach means that their conditions such as Jardiance, which is utilized to manage diabetes as well as some other comorbidities as well, means that they have their blood sugars in control. They stay out of the hospital. They don't have complications associated with diabetes like strokes, heart attacks, peripheral vascular disease. Ultimately, it means that we keep people out of the hospital. We keep people from the morbidity and the mortality associated with diseases like diabetes.
So I'm going to ask you a question about the medical profession and vis-a-vis this issue. And maybe you'll feel comfortable answering. If you don't, just say so. But it strikes me that there are a handful of drugs which we are bombarded with when it comes to advertising. You just can't watch a football game or frankly anything on your television without getting an ad for a new drug, or many times drugs you know pretty well.
Yeah.
The fact that we can pronounce and even spell Xarelto at this point is proof positive that we've certainly been trained with all these ads. I'm assuming, and you tell me if I'm wrong, that the pharmaceutical companies have basically decided if we can convince the ultimate consumer to go into the doctor's office and say, I need Xarelto, I need Wegovy, whatever it happens to be, that the doctor is going to prescribe that, as opposed to questioning whether or not it's necessary or whether there's a affordable generic. Is that true?
Yeah, I mean, I think that is the strategy. Not only do they advertise directly to physicians to encourage us to prescribe these medications, but they also encourage patients to go in the clinics and the hospitals to ask for these medications. For example, the drug that we've all been talking about today, Ozempic, we're constantly as physicians being bombarded with questions about their ability to get on Ozempic, just to find out that the patients can't afford Ozempic. I think the list price for Ozempic is around almost $1,000. And so they certainly, this is certainly a strategy, I believe, from the pharmaceutical industry to encourage patients to ask for the medications that they see on the television screen. And oftentimes, patients aren't even aware that these medications are applicable to their situations. And we as physicians have to educate them and tell them why, this medication is not appropriate for your condition.
Let's take Ozempic and look at some numbers. Novo Nordisk sells it for $71 in France, $59 in Germany. United States, they charge patients $969, and the price is only going up. And I can understand the demand are coming from the consumer side. Anything that is reduction in weight, which doesn't involve strict adherence to diet or exercise. People have been looking for that miracle cure for a long, long time. And it's going to create an ethical issue for us too, unless we bring the price down to an affordable level, in terms of the fact that weight reduction in and of itself, I think, is beneficial in almost every circumstance. Mm-hmm. And so how do you react to that?
Well, my concern is, again, for those patients who Ozempic is not appropriate for. There's certainly conditions and situations where medication is not the right answer to address weight reduction. In some cases, surgery is more appropriate for patients with high BMI scores. And so my concern is that those patients who come in asking for the medication, often for some of them, that medication is not applicable to them. And then for the patients who it is applicable to, most of them can't afford to even take the medication for us to prescribe it to them. So I think that there's certainly, it's issues on both sides.
Dr. Sandsmark, let me ask you a question that I raised earlier with the first panel. What's going on with Walgreens? Why is it when you go in there, you have to wait in line to get a prescription filled? I had to return a third day to get a prescription filled at a Walgreens smack dab in the middle of Chicago. And you better pick the time of day when you're coming. If it's any time near the end of work day, the lines are just unbearable. And here we have a situation where they're saying, well, the answer to this from Walgreens' corporate perspective is we're going to have to start closing drugstores. Closing drugstores, how does that may solve a corporate financial problem, but it certainly doesn't address the basic problem of people waiting in line forever and ever to have a prescription filled.
It's certainly not going to lead to better health care outcomes by closing pharmacies. I think a lot of it has to do with how a lot of retail pharmacists are treated. There's a lot of burnout with staff, not only the pharmacists, but technicians. They're forced to administer vaccines, counsel patients, and, fill hundreds and hundreds of drugs each day. And so there is a lot of burnout in there. These corporations are having trouble finding staff, so aren't able to keep their stores open. And then going along with the reimbursement rates from these PBMs that, yes, some of them are controlled by big pharmacy chains, but some of them are not. So you see the pharmacies as an individual getting squeezed by the low reimbursement rates on these ever-increasing prices on these drugs.
I'd like to invite Professor Sachs and the Attorney General to comment on the PBM experience that I've just described, any aspect of it.
Deputy.
Oh, sure. So in terms of the prices of prescription drugs, I'll defer on the question of independent pharmacies. In terms of the prices, there's clearly a role for some type of actor to negotiate for lower prices for drugs. But we've heard already about the ways in which PBMs don't seem like, in many cases, they're passing on the discounts that they're getting to insurers or to patients. And so in my view, we should think broadly about opportunities at the federal level and even at the state level for PBM reform. So you might have, for example, a regulatory reform or statutory reform that acts on the PBMs themselves, but you could think about a reform that would affect another actor in the healthcare system to push back on the problems that we're seeing. And so the Inflation Reduction Act, I think, is one example of this. So if you look at, for example, the Federal Trade Commission regarding PBMs and their conduct in the insulin market, one of the concerns is about patients' exposure to these really high out-of-pocket costs. You could respond to that, and maybe we should respond to that by looking at the conduct of the PBMs themselves. But another way to respond to it is, as the IRA does, it caps Medicare beneficiaries out-of-pocket costs for insulin at $35 per month, and it has this additional out-of-pocket cap in the Medicare Part D program as a whole. So one option is to look at reforms that address the PBM itself, but another is to say insurers are working with the PBMs in this way, and that relationship is subject to some of these concerns that might be harming patients. Let's look at that harm to patients more directly. So that's maybe just one point I would make.
Attorney General.
Yes, Mr. Chairman. The transparency is desperately needed. As we initiated our first investigation into the PBM that I mentioned earlier, getting to resolution was rather quick because they knew what they were doing was inappropriate.
Inappropriate. From the Attorney General's point of view, I might use a different word, but go ahead.
Yeah. There's stronger language that could be used. It's unconscionable because, as mentioned by several speakers today, the role of the PBM is the opposite of what the effect has been, is to be able to negotiate to drive down the costs, and the impact on end users, the patients, is that they're not using their medication or they're not using their medication appropriately. And the consequence can be fatal in some instances. The question that we're faced with state actions to regulate PBMs is whether we're preempted by the feds, and that's why we've been trying to use both efforts to encourage and protect state efforts to control the pricing, as well as to encourage Congress to be able to get some transparency, get these PBMs to furnish their pricing data to the feds as well as state payers.
Ms. Brandt, as you described it, I'm impressed by the fact that you've been able to juggle all these numbers and how they apply to you personally. And you seem to have made it through this thicket, but you describe people who have not been able to do so. Do you think this notion of $2,000 a year maximum out-of-pocket expense, also define maybe $40 a week is the most that you can have to pay out of pocket. Do you think that this is a cleanup of a system that is too complicated?
It might be. I'm a person that charts everything. So every year I compare the medication programs and I write everything to how much every one will cost me. Not everybody does that.
I think you could be an influencer.
I'm yelling at people all the time. People have told me, oh, I don't look at it. I just pay the same, do the same. So I'm kind of yelling at them, but I think it's such a wonderful addition. The $2,000, I'm very, very happy.
It does make a big difference.
Big difference.
Dr. Sandsmark, when it comes to the role of the pharmacist, I think we ought to put a couple things on the record. What does it take to become a licensed pharmacist in the state of Illinois?
Usually about 6 to 8 years of schooling, and then
Beyond college?
that'd be total.
Pardon me?
Yeah, beyond high school, that'd be total.
So it's 8 years.
Yeah, depending on which school you go to, yes,
Yeah.
it'd be up to it.
Is it an expensive education?
Probably about $250,000 to $500,000, depending on which school you choose.
And ultimately, these pharmacists are still in high demand, right?
Very, very much so.
And how many pharmacy schools do we have in our state or nearby?
I think we're up to like 5 or 6 now.
Uh-huh. That's
It used to be only a couple.
And you work out of the hospital, the Iroquois County Hospital?
Yes.
But you do retail?
We do everything. Might go from mixing a $100,000 chemo in the morning to filling a $4 antibiotic from a patient in our urgent care. So it's really all over the board.
Professor Sachs, I can't tell you how many times I've heard on the floor about the freeze innovation and preventing new drugs from coming to market. You teach a course on that, don't you?
I do teach classes on innovation in the pharmaceutical industry, but also on access to new medications.
The cancer drug Keytruda had $25 billion in sales last year. $25 billion. The revenue for this single medication is on par with what MasterCard or McDonald's Corporation earns in a year. How is it possible? How can it possibly be that a penny less in profit to big pharma will stifle innovation?
One of my favorite quotes on this topic is from former Health and Human Services Secretary Azar, who himself was a former pharmaceutical company executive. And he referred to this as a tired talking point, right? He said, it's not the case that if 1 penny disappears from pharma profit margins, American innovation will grind to a halt. And yet, over time, we certainly have seen the pharmaceutical industry oppose all kinds of measures of drug pricing reform, from the larger scale drug price negotiation programs to much smaller scale bills that would focus on particular patent or FDA abuses. And so in my view, what we really care about is the value of innovation to patients. It's about delivering real new clinical value for patients and reforms that preserve and protect that value rather than just the amount of innovation are really what matters. And here, one thing about the Inflation Reduction Act, the IRA's drug price negotiation program, is it really centers that concept of innovation that delivers value for patients. So Congress specifically directed Medicare to consider, as part of the negotiation process, factors like whether a drug is a therapeutic advance as compared to existing therapeutic alternatives, the drug's comparative effectiveness, and whether the drug addresses unmet medical needs. Those are the kinds of things where Medicare is directed to consider whether this drug delivers more value for patients. If so, maybe we should pay more for it, rather than if there's a drug that's one of these, you might use the term Me Too drugs, but doesn't provide a new mechanism of action or a new option for patients.
We also know that pharmaceutical companies spend more in sales and marketing than they do on research and development. In 2020, Johnson & Johnson, one of the leaders, spent nearly twice as much on sales and marketing, $22 billion, as it spent on R&D. GlaxoSmithKline was even worse. It spent $7 billion on research and development. Less than half of the $15 billion is spent on sales and marketing. Dr. Douglas, you seem like you're aware of this. Have you discussed this with people in the pharmaceutical industry?
Yeah, certainly the uneven spending in terms of on advertising and marketing versus the actual research and development. I think that a common conversation amongst my own colleagues and around the hospital is the fact that in America we prioritize capitalism, right? And there's nothing wrong with turning a profit, but when that profit takes priority over people, especially in the healthcare industry, that's when it becomes a problem. And people are it's not an over exaggeration that people are dying because they can't afford the medications that they need, and they're spending much more time in the hospital and emergency department. When we look at you quoted the Johnson & Johnson numbers, Novartis spent $14.6 billion in advertising and 9.9 in research and development. Pfizer spent 11.4 billion in advertising and 6.6 billion in research and development. I have a hard time grappling why these numbers, well, one, why would your advertising costs be significantly higher than research and development, but why they would even be close in terms of numbers. And so I think that it is a moral hazard on the behalf of the pharmaceutical industry in order to turn over large profits. And, another point I want to make is that we talked about the evasiveness of the pharmaceutical industry in avoiding legislation to regulate these prices, and industries like the hospitals and some of our clinics, our larger scale clinics that get a lot of bad rap about care and affordability of care are being gouged by the pharmaceutical industry as well. We talk about the 340B program, which is currently under attack by the pharmaceutical industry and some other opponents of the 340B program. But those type of programs that make prescription drugs more affordable for hospitals and patients allow us to provide resources in strapped environments like at the University of Chicago, where we care for a large percentage of Medicaid and Medicare patients. So these programs that they've the legislation that they've evaded and the regulation that they have evaded from making prescriptions more affordable is harmful to patients, and it leads to less and less poorer outcomes in terms of healthcare outcomes in our country.
Now, the pharmaceutical industry is going to counter that they put these ads in the air for consumer education so that they can learn more about these drugs. I'm going to ask you about one of the drugs and one of the statements that's made over and over again. The drug Xarelto. Mm-hmm. The warning is this: don't take Xarelto if you're allergic to Xarelto. Tell me, as a doctor, what you make of that.
Well, I think oftentimes in a lot of these advertising, we all see that the ads on the television about all the warning signs and how quickly they rattle off all the potential side effects or potential hazards to taking these medications, which is important for people to know and to be aware of. But there's evidently not a priority for people to know that. Otherwise, they wouldn't be the last 3 seconds of the commercial in these advertisements, right? So I think it's important. The transparency about the harm and the risk of taking these medications is important, but it's not a priority for the pharmaceutical industry, and it's a marketing tactic. There's a science to marketing, just like there's a science to medicine. And there, I think in one of the previous hearings you had, one of your colleagues on the Judiciary Committee talked about that the ads are a cure for loneliness, right? And how we look at these ads and the people start off as depressed and sad because they are dealing with the disease, and then at the end they're surrounded by family and loved ones
marching down the street.
Yeah. And that's not reality, right? It's a marketing scheme by the pharmaceutical industry to encourage and inspire patients to go and purchase or lobby their physicians to prescribe those medications.
Well, I kind of challenged the industry on consumer education when Senator Grassley and I introduced a bill which said that every one of these ads had to contain a disclosure of the actual list price of the pharmaceutical drug, so that the people who are watching this ad and thinking about, maybe I can march down the street too, having lost 35 pounds. Maybe that's in my future as well. Well, we introduced this, and it turned out the pharmaceutical industry did not want to educate any American consumers on the actual list price they set for the drug itself. Do you have any idea what the number one advertised drug is on television now?
I'm not aware.
Well, when you hear the name, you will be. Rinvoq. Mm-hmm. Rinvoq. Any idea? Perhaps Dr. Sandsmark, you might know this. Do you know what a monthly prescription of Rinvoq cost?
I don't think I've dispensed that one before. which is probably fortunate for my patients because I'm sure the price is going to be rather high.
$6,100. $6,100. Now, if you knew if the ad were flashed on the screen while you're watching this ad, you might have second thoughts about whether or not I want to recommend that to the doctor next time I go in. Now, I don't want to stop anybody from a legitimate conversation and exchange with a medical professional. I'm not suggesting that at all. But this is not designed for legitimate information to be given to consumers. It is designed to market a product. And it's very successful in that effort and what they're achieving. I want to ask the Attorney General a question. When you join these other attorneys general on an amicus to the Ninth Circuit Court of Appeals supporting an Oregon law that requires pharmaceutical manufacturers to annually report information for certain types of prescription drugs, why is it important for the states to be able to provide more transparency?
Yeah, as I mentioned with regards to the PBM, having everything occur certain allows for inflated pricing and more transparency does, allows for state and federal regulators to rein in some of these practices.
Certainly does, and I think we made that point today. Dr. Sandsmark, let me ask you about a specific pharmacy near my home in Springfield. I've heard concerns from independent rural pharmacy owners like Dave Baggett, Petersburg Pharmacy in Menard County. He's highlighted the systemic underpayment by PBMs to small pharmacies and how these middlemen steer patients to their preferred networks. The Federal Trade Commission has also found the same thing in enforcement against the three big PBMs, CVS Caremark, Express Scripts, and Optum for anti-competitive and unfair rebating practices. This is a complicated subject, but I'd like to ask you and Professor Sachs, we need more transparency around PBMs, as the Attorney General just said. Can you help us unpack these issues?
So first of all, preferred pharmacies is a loaded term, right? So preferred doesn't mean more affordable. It just means that the PBM wants you to go there. It doesn't mean you're going to save money there. Even on the Medicare Part D website, patients can go and see that one insurer might say that a chain pharmacy is preferred. But if they were to select a small independent pharmacy like the one you talked about, that pharmacy might not be preferred, but more affordable for the patient at the bottom line annually. So you have to see who's calling it preferred, right? Is it the PBM calling it preferred? That's steering you towards that. And we see the low underpayments all the time on these brand name drugs that we've been talking about all morning. Those are the drugs that a lot of times we're losing the most money on, right? The independents are. So 20% of our prescriptions each month, we're usually losing some amount of money to the PBMs because they're not paying us enough for what we're paying it from the wholesaler.
So they make the drugs available, but they charge prices which you can't recover at the counter.
Yep, exactly.
Professor Sachs?
So one, I think of the real challenges here, and we've heard a little bit about this, is the role of vertical integration and the ways in which these PBMs are incorporated into pharmacy chains or insurers or other parts of the drug pricing supply chain and ecosystem, which makes transparency particularly important, but also even more complicated. So we heard already, for example, reference to this New York Times series about the role of PBMs. Something that comes up in that series is about the role that PBMs are now creating these GPOs, these group purchasing organizations that they're separating out from their core PBM functions, and whether through those GPOs they might be siphoning off additional fees or other services. And it's very difficult to know. And so transparency or sort of other oversight in general might be helpful in getting at that information. Another point that comes up in that news series and also in the interim staff report from the FTC from earlier this summer is this question of PBMs now introducing their own co-branded biosimilars and in some cases preferencing them over biosimilars from other manufacturers. That's something where there also has yet to be, I think, a real sustained look at whether that's pro-competitive or anti-competitive. And so there's a whole range of practices that have been raised in these reports that it'd be helpful to know much more about.
It appears there's another process underway. Some of the largest pharmaceutical companies have gone further. They have launched new telehealth platforms. Now patients seeing a drug ad on social media can, quote, click here to talk to a doctor about a company's advertised medication. These platforms link patients with hand-selected healthcare providers. The ensuing visits are often brief with little review of health records or histories. It makes a healthcare appointment more like an Amazon shopping experience. And the financial relationship between the drug company and the doctor raises concerns about inappropriate inducement of prescribing. What concerns would you have about pharmaceutical companies' hand-picked doctors writing prescriptions for patients who are connected via their own ads? Dr. Douglas?
Yeah, I would have significant concerns. There's financial incentive for these physicians to prescribe medications that may not be the most appropriate for that patient's situation. So I certainly, I'm not personally aware of any physicians who are employed or work through telehealth and are supported through prescription drug industries, but I certainly would be concerned that there's incentive for the physician to prescribe medications that won't necessarily benefit the patient or be appropriate for their situation.
Professor Sachs?
Well, as a health law professor, something we talk about often is the independence of the medical profession and the importance of physicians being able to make independent medical judgments based on clinical evidence about what might be best for their patients. And so there's a whole series of different laws that are designed to make sure that physicians are exercising that independent judgment, maybe that they're not being financially induced, right, by other actors. And so I'd have to look more at that case study in particular, but that certainly would be something that would be potentially concerning in thinking about the role of the physician and the relationship with their patient.
I want to thank this panel for their contributions to this hearing. This hearing has really laid out in real terms how the market failures caused by Big Pharma's exploitation of the patent system and bombardment of TV ads have made medications unaffordable for many people. The perspectives we heard from patients, pharmacists, providers, and legislators are a call to action from my point of view. We need to build upon the Inflation Reduction Act. For Ms. Brand's observation, we've got to have affordable drugs. Your money or your life is not an acceptable outcome from this hearing. The perspectives we heard today help us to build upon that aura and bring down the high cost of prescription drugs. I'm not against pharmaceutical companies making a profit. I'm for it. I wanted to incentivize them to find new cures, new approaches in medicine. What we have now in this country is just almost indescribable. Try to get somebody to describe the role of a PBM. Attorney General, there was a full-page ad in the New York Times not that long ago from the PBM industry saying, we're not middlemen. I thought they were middlemen. Completely lost the role that they play. We need to continue to incentivize pharmaceutical companies to develop these drugs while ensuring that they're accessible to Americans who need them at a price they can afford. The hearing record will remain open for a week for statements to be submitted. Questions for the record may be submitted by senators by 5 p.m. on Tuesday, November 5th, a day you should remember. I want to thank the witnesses again for coming. This hearing stands adjourned, and that's the end of your vacation, Ms. Brandt.